Well, good afternoon, ladies and gentlemen, and a warm welcome from a cool Cape Town. It's my great pleasure to be with us. Our two co-producers here are Professor Steve Jeffrey, and he's a urogynecologist. He certainly doesn't need any introduction. I consider him one of the 10 best urogynecologists in Cape Town. Now, with me here is Dr. Willécia Vermaak, and you see her picture over there. Is that you, Dr. Vermaak? Yeah, there she is. Dr. Vermaak, as you know, is a person from Pretoria with a special interest in sexual health. And she's in fact joined the team at My Sexual Health to better treat patients with sexual health issues with the help of a multidisciplinary team. And we look forward greatly to having a talk this afternoon. The talk is entitled Genitopelvic Pain and Penetration Disorders with a Focus on Vaginismus. It is sponsored and underwritten this afternoon by Mindray, and Amanda Mkhize will be saying a very few words and play us a short video in exchange for her sponsorship and underwriting this webinar. So next week, just to remind you, some of you would know, our speaker next week is Professor Philip Steer, and he is talking on fetal and maternal biomes. That's the great new thing, the great new frontier is fetal and maternal biomes. So without further waste of time, I'd like to thank Mindray as a sponsoring person. Amanda Mkhize, are you with us? And are you able to share your slides?
She's on at the moment, Pete.
She was a minute ago. No, she's back again.
No, I don't think
all right. So when she comes on, maybe at the end, Steve. In the meantime, I'd like to thank Wendy, and a special great thank you to Dr. Willécia Vermaak for genitopelvic pain, penetration disorders, with a focus on vaginismus. Over to you.
Thank you, and thanks for that introduction. I'm very excited to be here. So as you said, I am part of the My Sexual Health team. I'm actually a general practitioner, but we at My Sexual Health also have 3 practices. The one is in Cape Town, there with you, and we are actually at the Pretoria branch, me and my colleague, Dr. Willécia Vermaak. And then there's also another practice in Joburg. So Dr. Elna Rudolph, you will know, she's the clinical head of My Sexual Health. And what makes us so well, equipped is that we specialize in sexual health with a whole lot of different health providers, including physiotherapists and psychologists, sexologists, even occupational therapists. If you didn't know, there's a place for them in sexual health as well. So let me introduce this topic. So with genitopelvic pain and penetration disorders, there's a whole array of, things that fall under it. I will get to that shortly. And then I'm going to just focus on vaginismus because we can talk a long time about all the other different entities, but let's just focus on the vaginismus for today. So vaginismus was coined, very early by James Marion Sims in 1862 already. But the first time I heard the term of vaginismus was only in 2013 when I attended a pain conference and Dr. Elna Rudolph actually presented on vaginismus and the success of treating vaginismus. And, we've come a long way. Even now, every second patient gets self-diagnosed by Google with vaginismus. So yes, it's become a lot more common. And I think there's a lot of things to be said about treating it successfully still. So the DSM-5 actually combined the terms vaginismus and dyspareunia, and that's how we get the single entity of genitopelvic pain and penetration disorders. But to just go into vaginismus specifically, so just in simple terms, it's, involuntary muscle spasm of the lower third of the pelvic muscles during any kind of vaginal penetration. This can be during sex with tampons, toys, fingers, even a vaginal examination. But vaginismus is a phobic disorder. So it's characterized also by significant emotional distress, fear, and anxiety with the anticipation of vaginal penetration. And that's how we can distinguish it a little bit from dyspareunia, which is more the pain associated, in the genital pelvic area. So a subtype of dyspareunia is the provoked vestibulodynias, which is just a burning, intense sensation around the vestibular opening on attempted vaginal entry, which now you will see then overlaps. So there's a lot of patients that get diagnosed with vaginismus, but then also have dyspareunia. But then vice versa, dyspareunia can also contain a large, component of vaginismus. So vaginismus pain cycle, I just want to focus on and explain that, where the mind-body connection is. So the amygdala, the part of the limbic system where memories, arousal, emotions, all the reactive body functions are stored. In this area, there's internalization of certain life experiences. So we'll get to that later, exactly, examples of that. And this causes the limbic system to respond with vaginismus. So for instance, you've heard with your first sexual encounter, it will be painful, there'll be blood. You could have, UTI during your honeymoon. And this gets internalized, these messages. Now, with your first attempt to penetrate vaginally, even with a tampon or sexually, these pelvic floor muscles tense up, it braces, protects you against this potential threat. Then the tight muscles make this vaginal penetration painful and even impossible. Patients, they explain it as hitting a wall, literally hitting a wall. When they try to have penetrative sex. So now, this limbic system tells you, oh, yes, I've heard it's going to be painful, but now I've experienced it. So it reinforces this idea, that the pain and difficulty with penetration has been confirmed. And then it gets imprinted on the nervous system. So there's a sympathetic switch on of the nervous system. And this now, leads to any kind of anticipation regarding intimacy to be negative, and this leads to avoidance. And this can have a very draining, effect on sexual desire, and fueled by this fear. And on the cycle goes. So you can see how vaginismus specifically has a large psychological component to it. So if we can just quickly categorize vaginismus, primary and secondary. So primary is considered a lifelong vaginismus. Penetration of any sort has never been possible. You often get this with girls using tampons for the first time, anyone attempting sexual intercourse for the first time, or patients coming for their first time gynecological examinations. And we see it specifically in our settings with unconsummated marriages, some of these for as long as even 12 years. So secondary vaginismus, we can actually focus on, a patient that had normal penetration. So often a patient, after giving birth, but they had a traumatic birth experience, or a medical procedure that affected the pelvic muscles, episiotomies, urethral catheters, placements of IUDs, and now they develop vaginismus then after that. Then there's also a difference between the global vaginismus, but you also get patients with only situational vaginismus. So global vaginismus, we define as anyone with persistent symptoms more than 50% of the time for a period of 6 months or longer. And then situational vaginismus can be, anything like someone can have a normal pelvic examination with any problems, but they just can't, you know, attempt sexual intercourse. And then less commonly, you do also get patients that only has a vaginismus in a medical setting, but not with sexual penetration. I've seen this recently with a patient, secondary vaginismus, but after a traumatic IUD placement, she has vaginismus in this medical setting. So I would like to do our first poll, if Wendy can help me with that.
Hello, Wendy.
It's launching.
Thank you. So you can read the question there. What is your personal experience with vaginismus?
See a lot of vaginismus. Yeah. Cape Town's a resort city. They come straight from the Table Bay here. A lot of them are Arabs. Yeah.
Okay, so that's very interesting. So luckily or unluckily, no one with personal experience. But then, you know, there's a lot of the audience that has seen and treated vaginismus patients, but you can, you know, gain from more knowledge. I'm very glad. I hope I can provide some. And then, you know, the knowledge and training and diagnosing I can relate to. It wasn't really part of our curriculum when I was still studying. And it's actually very, very encouraging to have a whole category of sexual health covered now in pre-grad studies. We also present to the students sometimes about this. So this is very, very good to see. Okay, so with sexual health, I know it's a very daunting, you know, thing to engage in this topic with patients. So what I would like to do with this talk is to make it very practical. So we have an approach to any sexual health consultation with this PLICIT model. I'm sure you've heard it mentioned. If you haven't, I'll just quickly explain. P is the permission aspect. So this, now you engage in a conversation where you as doctor ask the patient permission. Are you willing to discuss your sexual health issues, but also the patient giving the doctor permission, you know, to discuss this and to reassure the patient that, you know, the sexual health issue is valid. So reassurance is also a very, very important aspect of that. Limited information focuses only on clarifying misinformation, you know, dispelling myths and, you know, just giving factual evidence and limited information. Then we go on to specific suggestions, which will focus on the patient's issues specifically. And then lastly, we will initiate intensive therapy. So if I can use vaginismus as the focus today, I'm going to go through the PLICIT model, how to approach this in a consultation setting. So if we start with permission, it's very interesting to me always that 72% of patients in studies have shown that they feel actually comfortable discussing sexual health issues with their providers, but only 73% of them want the clinician to initiate this conversation. So they want to discuss it, but they won't initiate it. Then further data shows that, you know, only 74% of doctors actually feels comfortable to initiate it. So this is a bit of a conundrum. So if we look at the incidence of vaginismus, it's only 2 in 1,000 people, roughly. These, you know, data is very difficult. It differs significantly from country to setting. In some of the Western countries, it can be anything between 1% and 7%, but in specialized clinics like ours, you know, about even 68% of our patients suffers from vaginismus. It's very interesting. There's a recent study in Turkey that also shows an incidence of even more than 50%, which I would like to go and, you know, look at that reasons. And then female providers are also more likely to discuss sexual health issues than male providers, 45% versus 34% respectively. But, you know, just to see that the incidence is there, but not that prevalent. And then how to help you, you know which patients to specifically ask about, you know, these symptoms, and maybe then identify the vaginismus. I roughly put it into two categories: the patients that has pelvic pain and the patients with emotional distress and fear and anxiety. So pelvic pain, you know, you see this in your practices a lot. It's anything from chronic UTIs, recurrent candida, STI infections like your herpes infections, that's painful, anything that causes low estrogen, you know, breastfeeding patients. So your 6-week postpartum patient can develop secondary vaginismus from that pain. Anyone going through menopause, and then, you know, there's also the lichen sclerosis in that group of patients. That's very painful. I've had many patients coming saying, I have vaginismus, and then they were actually suffering from lichen sclerosis and more like a vestibulodynia more than a vaginismus. Then also primary ovarian insufficiency, also with a low estrogen. Any other pelvic pain with exams or procedures. And then, you know, if we go over to the emotional distress and the fear and anxiety, these are patients with very strict sexual scripts. Any fear around becoming pregnant. And then, unfortunately, sexual abuse victims. About 20% of these patients will develop vaginismus. And this can be trauma directly experienced or just witnessed, you know, those experiences being internalized as well. But also just beware, not all vaginismus patients has a sexual abuse history. A lot of these patients actually is made to feel that they blocked out some kind of a traumatic experience, which is not necessarily the case.
Willécia,
So yes.
Sorry, can I just interrupt if I may?
Yes, please.
You haven't, here in Cape Town, which is a resort city, we have a huge number of people, not 100 yards away from me, that are in these new hotels that are on honeymoon. And a surprisingly large number of them knock on the door with vaginismus. Now, I would have thought that the incidence is much higher than that figure that you quoted.
No.
Do you find that perhaps there are other influences, religion, background, mores, that actually pay a price? Because if you have a woman that has had prior sexual experience, is it true that she has less vaginismus than a woman that is sexually exposed in the first time here in Cape Town? What is your opinion?
So yes, definitely. I'm gonna show you now in the next part. You know, myths around sexuality that plays a role. There's this very the first qualitative study regarding which cognitions plays a role in vaginismus patients. You'll see it's those fear-based, disgust-based principles.
Okay, thank you.
But I understand you right. Yeah, those places those patients in a higher risk. Yeah, the incidence is very strange. You know, you get a lot of different contradicting data. I think it's difficult because partly to do studies because the definition of vaginismus and the term of vaginismus is not always the same. And I think it's a difficult study to do. A lot of patients don't even know they have a condition. You know, it's normal for them, especially primary vaginismus patients. So yes, I agree. I think the incidence definitely could be much higher than that.
Higher. And then so they turn up over here, knock on the door, and they come and they tell you, and they want to be treated in half an hour to go home and have a wonderful honeymoon. And I must say that you need a magician to actually offer them what they want. But you're going to tell us how to do it.
No. Oh, shame. No. So this is where this comes in, eh? I'm glad you raised that actually now, because now you can at least give them, you know, limited information. You're not going to treat them in half an hour, you know, not even in a honeymoon period of time. We'll get to the treatment later. But, you know, the limited information you can actually give them is to clarify misinformation, you know. So this actually helps a lot. So you know, most of those patients come and they ask me, but doctor, am I broken? Will I ever be able to have normal sex? You know, and then I'm asking, you know, what is normal sex in your definition? And then most patients, you know, they don't realize sex is pleasure between two equals, you know, equal pleasure for both partners. A lot of patients just see normal sex as penetrative sex. And this actually, you know, it just shows that it's a very male-orientated, pleasure-based idea where I'm sure you all know that females, you know, only 18% of women actually experience orgasm through penetration. So the rest of them experience orgasm with clitoral stimulation. So these patients, even if you do have vaginismus, I mean, it's obviously going to be difficult to now think of it in a different way, but you can still experience pleasure. And we try to teach patients that as well. While we are treating this penetrative difficulty, you are more than capable of also experiencing pleasure through clitoral stimulation. And that's a very, very important aspect. And it's quite a revolutionary idea for almost all the patients that we see. So this is the study that I spoke about, Ward and Ogden's study in 1994, which, you know, determined a lot of cognitions, fear-based, disgust-based cognitions leading to vaginismus, placing patients in a higher risk. And these are things just like, you know, sex is dangerous, pregnancy is frightening, you can get damaged, you know, childbirth is frightening, sex is painful, or it's undignified, sex is disgusting, or it's nice girls don't engage in sex. Pleasure is not allowed. It's a marital duty and all sorts of things like that. So yes, I think definitely this places the person in a higher risk. And I will get to the treatment options later, why it's so important then to engage with a psychosexual educator or therapist to go and look at these internalized messages. And this brings me to my next poll, actually. So Wendy, if you can just pull up the next poll, please. So this is a little bit of a pet project to me to ask patients how their first sexual education and messages, what it was.
Okay.
Okay, so I think we all had the same sexual education, limited biological aspects, 42% of you, and then 38% I think forms a large part of that as well, you know, exclusively focused on avoiding unintended pregnancy and other risk reduction of infections. But, you know, it's positive. 20% of you actually, there was some kind of information about healthy relationships, healthy intimacy. So that is very good. But I want to give you some more good news, because we are moving towards a more pleasure-focused sex education. And you can please go and read about this. We have a whole course on MSH on our sexology courses, free of charge and with 6 CPD points. So, you know, I'm selling it, but it's just so amazing to see the data on a pleasure-based sexual education. So, you know, with the background of not having this education, it almost doesn't make sense. But, you know, the Pleasure Project, which initially launched this in countries all around the world with the World Health Organization, they try to increase knowledge and positive attitudes about sex, you know, ultimately leading to better, safe sex and saving lives in the process. So hopefully we can really, you know, change the next generation. Obviously, we'll have less work then, but that's also fine. Of patients not suffering from these negative sexual messages, having a more positive outlook on sexual intimacy, the role consent plays, having respect and love for yourself, and that's why you engage in safer sex and all sorts of that body positive messages. So I just had to put that in as well, because I think it's a very, very nice thing to also share with patients that still has young children or, you know, adolescents, to really empower them to change the narrative.
Willécia, just one of the people have just made a comment that your poll doesn't include no sexual education.
Yes, that is very true.
Yeah.
That is a large component. And I think that's basically also part of the problem. You know, parents do not feel equipped to actually give good sexual education. And then, you know, ultimately you will get some sort of sexual education, even if it's only from peers and the media. And that can also be, you know, very unrealistic kind of expectations that's being set around sexual intimacy. And then, you know, so a lot of the studies, or I actually, I'll mention it later, the founder of the Vaginismus network, it's a support kind of a resource based in the UK. She actually said she had no trauma, no negative experiences. And basically when she went and looked at what could have been this, you know, trigger for her vaginismus, it was basically just a lack of positive messaging. It's not like it's a blatantly negative messaging, but the fact that you get taught, you know, don't engage in any sexual pleasure, females are not allowed to touch their genitals, things like that. You know, it's not overtly negative, but there's definitely a lack of positive information. So yes. Okay, as we get to the next part, I just want to emphasize, to be able to provide specific suggestions, we like to, you know, make a diagnosis in the first place, and then also to use a scoring system to get a baseline, and also use this to monitor, you know, progress with the treatment. So we use the FSFI score. That's the Female Sexual Function Index. It basically measures sexual functioning of women in 6 different domains. So desire, arousal, lubrication, orgasm, satisfaction, and pain. So you will see, you know, 3 of those aspects will already not be included in a patient that has vaginismus. So it gives you a very good idea also of the possibility of vaginismus. And then we also use the clinical examination, or we do a clinical examination. Obviously, this includes all other causes like skin conditions. You inspect the vulva, look for signs of infection, trauma, irritation. You can also do the superficial cotton bud evaluation to exclude vestibulodynia. And then if you can attempt a manual examination only with one finger, you can, look at specific trigger points around the vulva opening. If you see this patient has vaginismus, do not attempt a speculum examination, please. It's not necessary. We're moving away from needing to do a speculum examination. Obviously, there is also the cases with the imperforated hymen, those cases that you potentially have to then eventually also recognize. But, you can do a self swab for HPV screening. You can do a swab for MCNS. So defer the speculum examination, either for under sedation or when the patient has reached that point in the treatment progress. And then the grading system we use is the Lamont-Pesic grading system. So basically grade 1 will be a patient that is able to relax the pelvic muscles through breathing or so, conscious relaxation. And then you can attempt a pelvic examination very cautiously. It's also very nice if you can have different sizes of speculums and you can attempt a small speculum examination in these patients. And then you get the patient, they're just not able to relax the pelvic muscles. It's involuntary. You can't examine them. Grade 3 gets worse. They lift the buttocks off the table. They kind of retreat on the table. Grade 4, they just like shut those legs, like you can't even open the legs. They just retreat. You can't examine them at all. And then Pesic added a 5th grade, which then is the same as grade 4, but it adds these visceral reactions. These patients, they get palpitations, they hyperventilate, they shake uncontrollably, tremble, they even scream, become hysteric. They want to jump off the table, even sometimes, attack the doctor. And they can even feel like they're going to faint, like become unconscious or even vomit. So those are very severe visceral reactions. And I will specifically show you the approach we have in these patients as well. So, if you have these specific suggestions around knowing exactly specifically what kind of a grading or grade of vaginismus your patient has, you can now go over to intensive therapy. This just brings me to my last poll. It's just actually interesting for me to see. So if you're going to engage now in intensive therapy, we'll see the poll will come up now. So there are people that, start treatment with patients themselves, but if you feel like you need to refer to someone else, who would you refer to first? Okay. 15% will refer to a pelvic health physiotherapist, 59% to a specialized doctor in sexual health, or a 26 to a psychologist or a psychosexual therapist. So, okay, great. This is actually a bit of a trick question because there's no right first referral really. It really basically depends on the patient. I actually just want to, emphasize that you do not need to refer all patients to a psychologist firstly, but it is definitely a possible starting point. But, vaginismus treatment the success rate is actually so high with a multidisciplinary approach. There's several studies, there's different studies measuring different outcomes. Some just measure, the fact that you can now, tolerate penetration, but there's really some nice studies that measure a whole lot of, relationship satisfaction, the length of marriage, the possibility of conceiving and actually giving birth. So there's a lot of different studies that show that with a multidisciplinary approach and a multimodal treatment approach, there's a very high success rate. And this you can share with your patients, because 100% of patients with a multimodal approach will have 100% success rate. 95% in grade 2, 92 in grade 3, and 92 in grade 4. Grade 5 is a little bit more tricky. And then obviously the success rate of the treatment will depend on, the duration of them engaging in treatment. It's definitely not a short-term honeymoon-based treatment program. It is extensive and you have to prepare patients for it, but they do, this really brings them hope if they see at the end of this whole experience, there's a very high success rate. So if we look at the multidisciplinary approach, a large part of our treatment is dilators, obviously. So you get a whole lot of different dilators. The ones that we use is the very, very good quality medical grade silicone dilators. It's very, very comfortable. I know some people think you can't use silicone lubrication with them, which we actually do suggest using, because especially if you use the stub dilators, which is a bit of a shorter dilator, and you can leave that in like overnight or even for longer periods of time, a silicone-based lubrication is just much better. The water-based lubrications dry out, and if you have to remove it, it's quite uncomfortable. But just to remember, if you do then use the silicone dilators like we offer at My Sexual Health, you just need to clean it quite well afterwards with some, sunlight liquid, just to remove it, to prevent it getting sticky. And then we also like to, evaluate the patient, either by a pelvic physiotherapist or by a doctor to know which dilators to initiate. But not all patients need a whole set of dilators. But then some patients, can't even start with a number 1 dilator. They will start with just a cotton bud tip or 1 finger or 2 fingers. Generally, the rule is if a patient can tolerate a tampon, they can start with a number 1 dilator. And then if they can tolerate 1 to 2 fingers, they can start with a size 2 dilator. Most male partners with erect penises will be a number 4 or 5 dilator. So that's also an indication. If you can tolerate a number 4 or 5 dilator without pain, then you are only, ready to engage in penetrative sex. And we really emphasize this to patients, give them different options and regarding sexual intimacy and so on. Yes, we do even have, especially in the more complicated unconsummated marriage patients, that some of their partners can even be as big as a size 6. So those are quite complicated patients. And then I'll get to the medical treatment later and how we use the dilators there as well. The next aspect, in my opinion, those that said they will refer to a pelvic physiotherapist, well done, because we see in our setting 80% of the success lies with the physical therapy. The physiotherapists just do amazing work. They help with pelvic floor exercises and strengthening, but also with biofeedback, help the patient to relax the right muscles. They use different technologies for that, but it's quite an important aspect. And they do also help patients a lot with how to use the dilators, explaining which dilators they can actually use to gain access to some deeper trigger points and help release that as well. So that's quite an important part of the treatment. I know it's one of the aspects of treatment that patients often feel very uncomfortable with, but after seeing a very competent pelvic physiotherapist, and we have, pelvic therapists all around the country, even some overseas. So it's getting more and more accessible, the pelvic trained physiotherapists. And then if we go, yes.
Sorry, there's a question here. What about the use of local anesthetic with your silicone-based lubrication? Because some of the products people use, for example, for catheterization, Cathegel, they've got a bit of local lignocaine in. Can that be combined with your lubrication like Assegai? We've been told that's the one we should use by Elmer Rudolph. Assegai, which is the silicone-based one. Is it necessary, or is that overkill?
No. It's a very, very good question, and I'm getting to that. But yes, it is a definite possibility. So yes, I'm going to get to that and explain.
Another quick one, maybe you're getting to it as well. Veronique Earcoat says, where can you buy those? You buy those online at My Sexual Health, ne?
Yes, and it gets delivered to anywhere in the country. It's really very good quality silicone dilators. Obviously, you can get it elsewhere as well. I know overseas, I've never seen it in South Africa. You even get some of the silicone dilators that has a hollow tip where you can insert a vibrator. So I'm getting to that later. So if you can, combine that as well, to incorporate this, the dilation into pleasure as well. So yeah, you get a whole different range. But I think the silicone ones are the more comfortable ones. You do get
thank you,
and those as well. So psychological support, as I said before, is really also important. Not just for the patients to realize where these maybe internalized messages come from and to deal with that, but to also keep the patient motivated. So 81% of patients really benefit from psychological support as well. Specifically counseling and relationship support as well. It can be really taxing on a relationship. So if you have a partner that's not supportive, or it can be difficult. So these therapies mainly consist of the cognitive behavioral therapy, CBT, but you also get the body up approach, which is more like breathing and relaxation techniques, manual feedback. There's a lot of studies being done on the vasovagal stimulation to relax the sympathetic nervous system activation in the vaginismus patients. So that's also a big part of the multidisciplinary approach. So if we get to the medical treatment, we definitely use topical treatments that can contain, we use a combination of a lidocaine, prilocaine, almost similar to EMLA, that we mix sometimes with your vaginal estrogen, because those are the patients that really suffer also. So you need to really add the vaginal estrogen in those patients. If it's a patient with a cancer history, all of us know it's safe to use the vaginal estrogen, but you can definitely then replace it with something like a vaginal moisturizer, which contains hyaluronic acid. We have that on our shop as well. It's called Hydro V, and you get it in a gel form and suppository form. So that's also nice. And then we use Botox injections. I know in terms of vaginismus, Botox injections has become this quick fix approach. We find that really almost only 1 in 10 patients really need Botox. The rest of the patients will have successful treatments without this. But if I now go to our, grade 5 vaginismus, these patients, you can't even use dilators. So what our approach is we use light sedation in the room. We try and create a complete relaxed environment. We even ask the patient to bring something that's a comfort to them, specifically bring someone with, also that they feel comfortable with. And then the physiotherapist can join in as well. And the physiotherapist actually then, guides us. We do use local anesthetic, even though the patient is slightly sedated. We just believe there's some kind of a sympathetic cognition of pain still. So we use bupivacaine to then also numb the area, and then we use the Botox injections, mostly in some of the superficial muscles. Sometimes it could be a little bit deeper. And the success rate is big. What we do then, we insert the size dilator, which we found their specific partner is. And then as the patient slowly wakes up and, experience this pain-free dilator that can be inserted directly after the treatment now, it has a big mental impact for them. So obviously directly after the Botox injections, you will not start with your biggest dilator. There will be bruising. It takes about 10 to 14 days before we will start then with the dilation process. But yeah, it's quite a breakthrough then after the Botox injections.
Steve,
Is there any questions there?
Now just ask Steve. He's Mr. Botox here. As I said, he's a wonderful urogynecologist, and he uses lots of Botox in the pelvic floor. Do you use it under this circumstance, Steve?
I haven't. I've got not even vaguely as close to as much experience as Willécia and her team, but I have done it, and I'll just be obviously very interested to know how much you use, and where do you aim to inject it? Have you got a little pattern, protocol that you use, or what is your technique?
So do you use it specifically in the bladder, the Botox?
Yeah, we use it a lot in the bladder. It's for overactive bladder patients, and we use 100 units diluted into 10 mils of saline, and we give about 20 injections of half a mil into each of the sort of corners of the bladder. So it's about 20 injections.
Corners of.
Well, yeah, I spread it around a grid of about 5 by 20 injections. So yeah, and it works extremely well for an overactive bladder patients. But I don't have a huge amounts of experience within the pelvic floor for vaginismus. I've done 1 or 2 patients where it has worked. So I would invariably refer them to you guys to do it these days. I mean, I think you guys have got a lot more experience for that.
So there are studies that look at, between 150 and 200 units. There's not much difference. So we tend to use as little as possible, 100 to 150. Also diluted with your saline. And then really depends on the patient. Most patients have a very bad, BC, bulbococcygeus, bulbospongiosis spasm, so that it works extremely well in those patients specifically. So then we aim to go from the very top, where the clitoris hood starts, and then we inject above and into and underneath that muscles. It's almost 20 injections in that, bilateral side. Sometimes you do get patients with a more deeper, maybe your obturator internus muscle, but it's a bit more difficult to really infiltrate there. And I don't feel that it's as effective in those patients. So if it's a patient, that's why I say, if it's a patient with really bad superficial spasm, it works really well, but it's not for everyone. It's a very expensive treatment, and mostly, it's those grade 5 vaginismus patient that benefits more on a psychological level. It's like a body up aspect for them. They can see now it's relaxed, there's penetration possible. and then they can start the process of the dilators. But the dilators and the physiotherapy is by far the biggest component of the treatment. And to answer the question from before, the topical anesthetic cream, we use a whole combination cream. We call it our 4x4 cream. So it gets compounded by Fagron, or one of the compounding pharmacies. So you can also apply that for 5 minutes before starting dilation. Patients, yeah, definitely. And then they still use the lubrication as well with the dilators.
I find that just in the few I've done, try not to use too big a needle, because I mean you can kind of run out of the little hole that you make. So try and use it like quite a thin needle.
Maybe a dental needle, Steve?
Yes,
Yeah,
we use dental needles. Yeah, like a dental syringe. Yes, yes.
Otherwise it's you find injecting and this kind of comes out. So
yes,
It was embarrassing if you squirt it in and it just squirts back in your face. So yeah.
Yeah, you're wasting the Botox.
Oh, your face?
Well, I mean, that's not a bad thing.
No,
But,
no. Okay. Sorry,
Yeah,
William, interrupted you.
No,
Steve
no,
interrupted you.
it's perfectly fine. I think it's valid questions. So coming to the end of this, as I mentioned before, this vaginismus is just one of the examples of resources you can provide to patients. Support is really necessary, with also other vaginismus patients, to normalize the condition and break this whole shame associated with it. So that's just my last message. And then obviously there's always a lot of opportunities to gain more knowledge. If this talk interested you in the sexual health aspect, there's a SASHA Congress coming up, the Southern African Sexual Health Association. It's in Johannesburg, so not in Cape Town like last year, unfortunately. But if you want nicer weather, maybe you can come and join us in Johannesburg on the 19th and 20th of October.
Thank you so much, Willécia. It's been wonderful and highly informative. And I mean, this is something that we're not privileged to have much exposure to. Some of us that studied here in Cape Town had Dr. Sapphire, and she's the doyen of contraception and sexual health. I don't know if you've ever heard of her, Dr. Esther Sapphire. And she was an absolutely wonderful resource. So we could use it. Unfortunately, I think she's passed away. I'm not sure, but your resource of the online webinars and web-based information is a great way of starting, and it can be used immensely quickly. And we can also use it as a online shopping, and use those products that you've mentioned. So thank you very much. We don't have Mind Ray, but Steve, there's another question from Veronique. What does she say?
Yeah, Veronique was also just asking about the placements of the injections and into the transverse perineum. How much would you give? But I mean, is it a sort of a judgment that you make at the time of injecting it, or how would you answer that question?
Yes, and that's why the pelvic physiotherapist also helps a lot, because if they've seen the patient before, they know exactly where the main trigger points are. So basically, we try and inject a little bit more in those main trigger points, but then also spread it around on the other superficial muscle areas. Yes. So it's not an exact science, no, unfortunately.
When the women say, are there any side effects? I know that this week, a woman wanted Botox, and she says it's safe in pregnancy. So I said, well, judging from first principles, I wouldn't give Botox to any pregnant woman.
No.
Are there any other contraindications, in your opinion, apart from pregnancy?
So I wouldn't say there's really contraindications. Maybe if someone had, a bad reaction on local anesthetic, or, something like that, but there's but you do have to, there's a small amount of patients that do suffer from a transient incontinence as well, so you just have to prepare them well, because as I said, there's a lot of bruising and pain initially as well after the procedure, so they tend to feel discouraged, you've made it worse. But it does, and it also doesn't last as long. There are patients where it lasts you know, we see them and then only 3 years later, after having the second child, we see them again. But most patients, we tell them it lasts between 8 and 12 months. It doesn't last so long.
What is the effect of vaginal delivery on vaginismus have? I know, does it cure your muscle spasm, or does it not? This being a phobia.
No, it doesn't. So that would be interesting. I don't have studies on that. It would be interesting to read about it. But most patients actually end up having cesarean sections. It's not
really.
Yeah, it's unfortunate, and I don't know if it's just part of our statistics in South Africa, you know, or if it's vaginismus specific. But it would be, I think that's a good area of research. Actually, we need a lot of nice more research projects in Africa and South Africa specifically in our patients.
Okay,
Interesting study.
Yeah, I tend to see quite a lot of patients with post pelvic floor surgery pain. It's slightly different because there's more of an anatomical defect. Often it's not specifically related to the muscles, but it can be related to something else like some scar tissue or
Yeah.
But you know, you do maybe a posterior repair, and you know, it's maybe be more suture based, etc. Do you tend to use those patients as well? Any specific thoughts about those patients who are specifically related to post-surgical sexual pain?
Yes, we do actually. So it would have been nice. You should get one of our pelvic physios to do a talk. But they actually see the patients before surgery, the pelvic floor surgeries, the anterior posterior repairs, and then also afterwards. So a lot of those patients need to learn new techniques on urination and defecation, specifically because they've learned, you know, an adapted way with the weakening of the pelvic floor. So that's part of the training afterwards as well. And it's actually very interesting. I do see that secondary vaginismus in those patients. Yeah. So traumatic childbirth, and then, you know, having a pelvic floor repair, it's just traumatic. It could be.
More questions. Anonymous says, where can one do the sexology course? So that's online, you said, didn't you?
So in South Africa, we don't have a formal qualification. So you can go overseas, you can do it at the European Association of Sexual Medicine. And then there's a course in Sydney as well, a 2-year course. You can also do an HIV-based course with a little bit of sexology in it. But we have training through the Sexology Training Club, which is really very good quality. We have international speakers doing the courses. You need to comply with a lot of, you know, CPD points and case study presentations, and attend 5 supervision sessions. You have a Q&A monthly. Yeah, so it's quite extensive, but it's very, very, very good training. So I would recommend that if anyone is interested, and it's very accessible, like you said. Anyone can join. Anyone can apply. Maybe
we've got time for one more question, Steve. Is there a place for Fenton's operation? Are you familiar with the Fenton's operation, Willécia? That's you're not. It's a medial or midline incision at what we would have called the fourchette downwards, and then suturing in the opposite direction to increase the outside diameter of the genital hiatus. Am I describing it, Steve?
Yep. Yeah.
Do you actually perform those still?
Well, absolutely. You know, sometimes you'll have a posterior repair that heals with a little bit of a web, or you know,
a windshield perineum,
or a you know, episiotomy, etc. I mean, I've got one of mine that I actually sent to Pete because, you know, by the time I'd seen her, she's kind of
pregnant,
tired of me. So Dr. de Jong actually ended up doing a Fenton's on it, and it worked very well. So, you know, it's that classic patient where you kind of almost see this web of tissue at the posterior fourchette where for some reason it's healed up a little bit too high and created this little bit of tissue there, and they do work quite well.
Yeah.
Just make sure you cut the right way, you know.
No, but also, you know, your question is this done for vaginismus? I don't think for vaginismus, no. It's done for a anatomical derangement of the anatomy of the fourchette, but not for vaginismus, which we've heard the options available, which none include surgery.
But on that point, you know, if you do see someone that has got some sexual pain post-surgery and you've got some scar tissue, be extremely careful going in and trying to excise it or you know, cut it, because I found that you sometimes end up you're going down a rabbit hole where you never really get out of it and make it worse. But one thing that I did want to mention that I have tried, that I don't know if you guys have, sometimes you get a patient with a very specific point of tenderness post episiotomy, post-surgery. And I've had some success with just a very local injection of hyaluronidase, a little bit of hydrocortisone and Marcaine.
And Botox? Would that help?
No, just a very specific injection with that, and that often releases the pain. We started to do it when I trained in the UK in London, and we actually did a article on it, and really very specifically for postpartum patients.
For a little neuroma in that area.
Not really even neuroma, a little bit of scar tissue can actually feel a very specific point tenderness, and we'll give that it's just 5,000 units of Hyalase, and a little bit of 100 milligrams of hydrocortisone and some Marcaine, and you just inject it there, and it works quite well. And sometimes just repeating it after a month gives improvement in more than 50% of patients. But that is a very specific point tenderness. It's not really vaginismus, but it's sexual pain.
Yeah, I think I just want to add as well, you know, if you have a patient that you've seen and treated with vaginismus, but they tend to still have a deep pelvic pain, I refer to the gynecologist, you know. And then also I've had one patient then, you know, not responding normally to treatment, and then under in theater, you know, when we swiped that posterior, there was actually like a cold abscess there post surgery. So you do get complicated cases. You can't really say always. And then, you know, I've never heard of the Fenton specifically, but we do see patients with those excised scar tissue kind of things. I don't know exactly if it's the specific procedure that was done, and maybe like you said, you know, just cutting away randomly on scar tissue just makes everything worse in the long run, actually.
And then just one last thing, one of my favorite medications or things is Premarin or Sinopause. We mustn't forget about that. Specifically in postpartum patients, remember it's a hyperestrogenic state. So, you know, giving that to postpartum patients often helps a lot. But we've all spoken about that. We'll check for atrophy too. But Willécia, this has been a wonderful talk. Your slides are amazing. Pete and I were just saying that we love the way you presented that as well. It's a very good way of doing it, and we really enjoyed your talk. Very difficult subject. I think you've really enlightened us. It's a heart sink for a lot of us to hear that patients are presenting with this problem, but
and they usually present as they're on the way out the door, Steve. Oh, by the way, I look at this terrible problem.
But I think you've most certainly empowered us, and I think even with your approach, we could possibly even make a start on treating these patients ourselves. But I think it's wonderful also to have access to My Sexual Health, and I know you guys do online consultations, and I tell patients that too. And I think you guys are more than accessible, even if you're not specifically in Joburg or Cape Town or Pretoria.
But there's a Durban chapter as well, Steve. Am I right, Willécia?
No, definitely. And even, you know, there's doctors all over the country, not, you know, necessarily at a accredited My Sexual Health practice, but there's credible sexual health providers, you know, all around the country. There's some of the gynecologists and GPs in KZN, in Nelspruit, in Bloemfontein. So there's a lot of different places. And as you said, you know, as far as we can, we then also do online consultations, because then, you know, the pelvic physiotherapists are more widespread. And then if they can do a thorough assessment and then discuss, you know, we can definitely start treatment as well. So yeah, there's a lot of different options.
Thank you so much, Willécia. And a great big thank you to Mindray, our sponsors, and looking forward to seeing you all next week, ladies and gentlemen. Same time, same place, Thursday evening for Professor Phil Steer, fetal and maternal biome. So good night, safe home, and see you all next week. Thank you.
Very much. Thank you very much.